Um, so I will start first. Nadine asked me to start first. And what I'm going to cover is a couple of parts of the 2024 statements. So this is the current statement. And whenever you guys see a new statement or practice guidelines, you should always understand who the writing authors are. So if you look here, all of the writing authors are cardiologists predominantly. We have infectious disease experts. We have people from Taiwan, and most of the co-authors are from the United States. I have no disclosures. And what I would like to start with is how to make a diagnosis of Kawasaki disease and how to initiate therapy. This is figure 1 in the 2024 statement. By the way, this is the reference to the statement if you need it. So when a patient is suspected to have Kawasaki disease in either the primary care office or the emergency department, the statement calls for performing certain labs that I will be sharing with you soon, and then consulting your Kawasaki disease team. That might be a cardiologist, might be infectious disease, might be rheumatology, or might be someone called a KD expert. And then from there, you look for complete Kawasaki disease criteria. If the child meets that, then you start therapy. First line therapy is always IVIG plus aspirin. We will talk about the doses soon. At the same time, you assess for high-risk features. On the other hand, if the patient is suspected to have incomplete Kawasaki, then we ask you to do the lab evaluation and the echocardiogram if needed. And then the team need to make a decision. Does the child meet the criteria? If not, then that's the end of their evaluation here, and they exit the pathway. I will be talking about what does it mean to exit the pathway also in the next slide. On the other hand, if the child meets the incomplete Kawasaki criteria, then they are treated the same. First-line therapy is IVIG with aspirin and assessing for high-risk features. If the patient has high-risk features, you look for that. In the absence of high-risk features, we will reevaluate to see if there is any fevers 36 hours after the completion of the first dose IVIG. If the patient has a fever after 36 hours, we call that IVIG resistant. At that time, we will call for using rescue therapy. On the other hand, if you have high-risk features at the beginning of your evaluation, then we ask you to give the child adjunct therapy. Both of these therapies, whether it's rescue therapy or adjunct therapy, it's called intensification of therapy. And the options I will be sharing with you also very, very soon. One thing that's important is to repeat evaluation with echocardiography every 2 to 3 hours if you have a child with Kawasaki disease. If the patient develops aneurysm, I will walk you through figure 2 what to do with those patients. Those who respond and their fever subsides are the ones that we will send home. We'll transition to low-dose aspirin. Because we gave IVIG, we're not going to give live vaccination for 11 months post-IVIG. And they are to be seen by cardiology. For all patients discharged with Kawasaki disease, they are to be seen within 1 to 2 weeks. Those with aneurysms, you will notice that we're going to ask to be seen within 1 week. And then provide KD education. That means when should they call you back to your office? When should they be readmitted? Fevers, peeling, things like that that you need to look for. Now, I keep saying exit the pathway. I just want to make sure that we understand the healthcare system where the guidelines have been produced. In the United States, patients are cared for within their pediatric offices. So it's either the pediatrician, the family practice physician who care for this patient for their well-being. They provide them with vaccination. They do see them annually for their regular updates and regular visits. So when we say exit the pathway, it's exit the pathway back to their medical home. What are the lab tests that we will ask the providers to do? First thing is a CBC, ESR, C-reactive protein, basic metabolic labs, some liver enzymes, and the urine analysis. We ask for an EKG and echocardiogram for patients with Kawasaki disease as well. A reminder about the diagnosis. For complete Kawasaki, you have to have fever for at least 4 days, and then you have to have 4 out of 5 clinical features. These clinical features may be a rash, conjunctivitis, oral changes, extremity changes, or cervical lymphadenopathy. The guidelines continue to state that you should look for alternative cause, and if the child has an alternative cause, then you don't apply the Kawasaki disease algorithm in those patients with confirmed alternative cause. Now, what does it mean to have incomplete Kawasaki? Incomplete Kawasaki means that you have some features, but not 4 or 5. You might have, 2 to 3 clinical features. For infants, we actually look for unexplained fever for at least 7 days. In the presence of either one of those two, you look for lab criteria or echo criteria. Lab criteria includes evidence of inflammation, plus at least the 3 of the following: anemia, elevation in platelets, low albumin, elevated white blood cells, ALT, or a urine white blood cells showing more than 10 in the high power field. On the other hand, if you don't meet the lab criteria, then you perform an echocardiogram. If your coronary artery Z-score is 2.5 or above, then you treat. That means that the child met the criteria. Now, in the statement, we actually included other clinical echocardiographic features. So if the child has a coronary artery disease score of 2 to 2.5, what do you do with that one? You look for other features: decreased ventricular function, mitral regurgitation, or pericardial effusion. If you have a 3 out of those 4, then you will consider that positive echo and you will treat. High-risk criteria in the 2024 statement looked at multiple different criteria across the globe, and we chose children less than 6 months of age, or left anterior descending coronary artery, or right coronary artery Z-score of 2.5 and above. The second part of the statement discusses what to do with a child who developed aneurysms in front of your eyes. So you do the first echocardiogram, you see an aneurysm, or the second echocardiogram during the acute phase and you see an aneurysm. What should you do? I take pride in having my co-authors adapt the algorithm that we established at Children's National. So the first thing is, you have noticed on your echo that the child developed an aneurysm. We ask that you consult with pediatric cardiology. At my center, we actually will transfer the patient to the cardiology floor from the general pediatric floor. And then you have 3 possibilities for the aneurysms: either a small aneurysm defined by a Z-score of 2.5 to less than 5, medium aneurysm, a Z-score of more than 5 but less than 10, and a large or giant aneurysm with a Z-score above 10 or an actual dimension of 8 or more millimeters. If you define an aneurysm, then we will ask for additional anti-inflammatory therapy. Whether the child was considered high risk or not, if you find them to have aneurysms, then for sure we need more anti-inflammation. And we will ask for a repeat echocardiography soon after to make sure that we know how big the aneurysms will get. For children less than 3 years of age, we sometimes have to do sedated echocardiogram because we're looking at teeny tiny structures, millimeters in size, and we need to make sure that we are measuring the accurate number. Once you give the anti-inflammation therapy and you repeat the echocardiogram, if the child continues to be in the small category aneurysm, then you are going to discharge that patient on low-dose aspirin. On the other hand, medium aneurysm, we can introduce low-dose aspirin plus Plavix for discharge. On the other hand, giant aneurysms are the ones that will need the whole 9 yards. They need double antiplatelet therapy, so aspirin plus Plavix plus anticoagulation. Anticoagulation could be low molecular weight heparin, could be Coumadin, could be the new direct oral anticoagulants. We actually, if the child is tachycardic, we will give them beta blocker to reduce the myocardial demand. And if the child is anemic, we also will give them blood transfusion. The goal of these two is to reduce the myocardial demand. Once the child is afebrile for more than 36 hours and the coronary arteries have stabilized on 2 studies, then we can discharge the patient home. The difference now is we are going to see the child within 1 week. We're going to continue to perform echocardiography on a weekly basis for the first 45 days. By the way, this is not a change from 2017 statement. This is actually copy-pasted from there, that we should be doing echocardiography on a weekly basis for the first 45 days. The reason why we are nervous with giant aneurysms is they have the highest chance of thrombosis and infarction, and that highest chance is in the first 2 to 3 months of diagnosis. We ought to be educating our patients about symptoms of MI. So for young children, it's non-specific, it's irritability, excessive sweating, or older patients, it might be GI symptoms, it might be chest pain that radiates to the left arm, and CPR education is a great idea. This covers the two figures in the statement. Now, I talked about initiation of therapy. I talked to you about intensification of therapy, and I tried to clarify that there is two ways to get to intensification of therapy, either immediately at the time of diagnosis because of high-risk features, and that will be adjunct therapy, or the child has failed IVIG, had continued to have a fever 36 hours after the completion of IVIG, that we will call rescue therapy. In the table that we provide, we will discuss the agent, some description about the medication, what doses to use, and if there is any additional recommendation. Gold standard therapy for Kawasaki disease is IVIG. We give 2 grams per kilogram over 8 to 12 hours. Now, if the child has Kawasaki disease shock syndrome, or if there is myocardial dysfunction, you might want to reduce the rate at which you're giving the infusion. And then what we learned with COVID and MISC is that children who were overweight or obese, the dose that we were using was really, really high, and that was associated with hemolytic anemia. So the consideration now is to use lean body mass as opposed to the current weight that the child has. And aspirin, the current dose that we use is medium dose aspirin, 30 to 50 milligram per kilogram per day divided every 6 hours. Once the child is afebrile, then we will use 3 to 5 milligram per kilogram per day, and that's what we will discharge the patient on. We have a lot of debates that continued with regard to the dosing of aspirin during the acute phase. We know that there is currently a trial looking at is it really needed to be medium dose or not. But for the sake of the statement that was released last month, we are advocating for medium dose. Don't administer NSAID because it impacts the efficacy of aspirin. Other therapies for intensification includes steroids, infliximab, or etanercept. For steroids, we provide in the statement the two different doses. The one came from Japan with the RACE study and one that came from North America studies. In the Japan one, we give IV 2 milligram per kilogram divided every 8 hours for 5 days with a maximum 60 milligram per day while admitted to the hospital. Then they go home on oral prednisolone, 2 milligram per kilogram per day divided every 8, and then you have a slow taper for 14 days. That's different than the North America studies in which the dose is given every 12 hours, and the maximum dose is the same. And then when we go home every 12 hours, and we monitor the CRP, make sure that it has normalized, and it's tapered over 2 to 4 weeks. We try to protect the stomach by giving famotidine. Infliximab, the dose that we advocate for now is the 10 milligram per kilogram. In the 2017, the dose at that time was 5. So now, based on more recent trials, we advocate for the 10 milligram per kilogram per day. And I provide here the dose for the etanercept. Now, this is an example of a trial that we actually reviewed for the sake of writing the statement. This trial was first authored by Jane Burns from San Diego. What the team did is they looked at patients who failed IVIG the first time. So they have a fever that persisted 36 hours after the initial IVIG. Those patients then were randomized into either a second dose IVIG or infliximab 10 milligram per kilogram. The primary outcome of this study was resolution of fever at 24 hours of initiation of the study treatment and ensuring that the fever does not come back for 7 days post-discharge. What the author found was that the primary outcome was achieved in 40%, on 40 out of 52, 77% of patients in the infliximab group, and in only 25 out of 49, 51% of the second IVIG. If you were to do the number needed to treat, you will see that the number needed to treat here is 4. For every 4 patients that you treat with infliximab, you will be able to get to the primary outcome. The duration of fever was less, the hospital length of stay was less, and we did not have as much drop in hemoglobin or hemolytic anemia, as we have seen with second doses IVIG. At Children's National, if you ask me what therapy do we use here, we actually now use infliximab as our intensification therapy for adjunct or rescue therapy. I know the debate between steroids and infliximab continues. I know that people take emotional and be stressed about what therapy is better. I feel like it's a tribes and they continue to fight. But for now, I am siding more with the infliximab. Other therapies that we have considered, cyclosporin. This one is more common in the Japan cohort, and we advocate that you use the neural, not the generic variation, because of there is a problem with absorption with other agents. We give you some guidance on how to give the medication. Anakinra is another therapy that had been used. And then some centers will still use second dose IVIG, and very rarely some centers will use cyclophosphamide. With that, I will end here. I'm more than happy to take a question.